Thank you everyone for coming this evening. As I said just now, we are actually streaming live to Facebook to a group of plantar fasciitis heel pain sufferers in the UK. So if you don't want to be heard live in the group, then save questions to the end and we'll turn off the cameras. We're also recording the presentation as well, and I'm mic'd up for that, so anything you say will be picked up by that as well. Okay, so I'm Jonathan Small. Thank you for coming to join us this evening. I've got a podiatric clinic around the corner, opposite side of this building basically. We don't have room to run talks there, so Claire, who runs Every Fitness here, kindly offered us this room, cosy room that we've managed to squeeze in today, and so thank you for coming. So we're going to look at plantar fasciitis and heel pain, and it's a mixed bunch. We've got a mixed bunch of people here. So who's here actually treats plantar fasciitis? Who gets asked about plantar fasciitis? And who suffers with plantar fasciitis or heel pain? And who's here just because they got dragged along by the other half? Okay, so we've got a mixed bunch of people, but we're all the same, aren't we? Humans are fairly much the same, but when you actually look deeper, we've all got differences, just like these Dalmatians. So this is a reference to the Mythbusting 101. Because not all plantar fasciitis is plantar fasciitis. There's all different types of it, and we're going to cover that this evening. First of all, did you know how prevalent heel pain was? Something like 1 in 10 of us will suffer with heel pain at some point in our lives. And it doesn't matter what we do, who we are, okay, what shape we are, what activities we do, everybody will potentially get it. So I'm going to take you back to this period in my life. This is my son when he was about 1 year old. He couldn't walk very much. He hadn't developed his muscles, his bones, his structure to be able to walk, so he got carried everywhere. And over a period of a few years, he grew up and he learned to walk and carry his own body weight, and his muscles and his bones developed progressively as he grew older. So now he can actually carry me around rather than me carrying him around. But he complains of heel pain. But a heel pain in a child could be very different to a heel pain in an adult. And we'll come later on to potential diagnoses. But I'm going to call on Evan a second to help us with this, so we can understand how our body functions in order to understand why we get heel pain and what we can do about it. So hopefully this will go to speaker now. And if not, then I'll hit return.
Oh, I didn't see you there. Hi, my name's Evan, and this is the Smarty Bot.
So Evan puts together YouTube videos around things that he makes.
Hey guys, today I'm going to be building the AI bot. So,
once we've done an unboxing video, and a quick reminder, these are all the pieces, so let me quickly take them out. We'll probably need on them.
So that's building a robot, and what we're going to do today is we're going to look at how we're built in order to understand why we get heel pain and the problems that we get. So who remembers this program, Telly? Robot Wars, yeah? Really good program, wasn't it? Yeah? How did all those robots get around? They were all on wheels. None of them walked. They all went round on wheels. Even the great Sir Killer-Lot was on wheels. None of them walked. And there's really good reasons why none of them walk. Because walking is really complicated. Now my son has decided he wants to turn his teddy bear into a walking, cuddling robot. So the other Sunday, he ended up with me trying to work out how robots walk, how we walk in order that his teddy bear can walk. And it's really complicated. So if we look at some robots that have been built to try and copy how we walk, and we look at that top one, and we see that he struggles a bit with forward progression. And he's struggling because he's got a heel at the back that's going to catch the ground if he doesn't lift it up there. You see? He has to lift it forward and then pull it forward so that it doesn't actually catch the ground and make him fall over. So another way around that would be to shift the weight from side to side, like in this robot. And you can see how he leans to one side, lifts the foot up to bring it through. And then we go to something that's got a bit more control, a bit more like human gait, whereby the heel hits first of all, and then the foot goes flat, and then he walks through and brings the other leg through okay. A lot more complicated design to this robot than there is to this robot. A lot more smoother gait with that going side to side than this is a bit jittery. But actually the smoothest gait comes in this last one. And you see there's really good coordination of walking there, of a robot, and notice the shape of his foot, okay, compared to the shape of some of the other feet. And this is really important for us to understand how we walk. Now they've cheated with this one because what they've done is they've effectively given him 3 legs as opposed to 2 legs. So he's always balanced and he hasn't got to worry about side-to-side balance. So when we were trying to design this teddy bear robot the other day, the biggest complication was, how do you stop them falling over when you take the one foot off the ground to walk? Come on in.
Sorry,
Okay,
I'm
no.
so sorry.
It's okay. Go and grab a seat if you want. Yeah, how do you stop yourself from falling down when you take your one leg off the ground? So when you're building a teddy bear robot, all it does is just fall over like that, because it hasn't got muscles that would hold you up. So let's look at why we walk and what's the purpose of walking. So this is a nice animation of somebody walking. Generally, we don't walk quite like that, okay? But you can see there is forward progression, smooth forward progression. The idea of walking is to get us from A to B. Not get us, get our heads, get our brains, get our mouths from A to B in a straight line, ideally. And so we developed all sorts of mechanisms with our muscles, our bones, our ligaments, our tendons, our nerves, our blood vessels, in order to achieve that process. And it's really quite complicated. So if we look at the way the leg functions, we start at the pelvis here, and we've got the leg coming down to the ground. And we're looking at a side view first of all. And when we're looking at how we function for walking, we're looking to see what patterns of movement there are. So if I play this one, we'll see that there are actually different stages to the walking motion. From a side view like this, we talk about rockers. And the rockers at the foot level are really quite important because it goes back to that robot walking. So the rockers, the first rocker is when the heel hits the ground and we rock over that heel. Remember that robot on the treadmill? We rocked over that heel. Then the second rocker is the ankle rocker when the leg bone goes over the top of the foot coming forward. And then the third rocker is the toe rocker when the ball of the foot is bending to lift us up. So 3 key rockers to progress us forwards. All of that is controlled from further up and what's happening with the pelvis and the legs and the musculature around here. Bear in mind what we said, if you take one foot off the ground, you're going to fall over. Okay. We've also got to decelerate forces that when we're bringing our leg through, actually we hit the ground slightly on the outside of our foot, and therefore our line of progression is slightly that way. So everything wants to collapse us down, and we have to fire to pull us back, to send us back that way. Okay? And if we look at the rear view of walking, then there's lots of rotations that take place around the legs in order to help us get that ground clearance and in order to control that foot coming down to the ground. And as a simple version of foot function, you get the heel hitting the ground slightly on the outside. I'll grab my bones because it's easy to show you. Heel hitting the ground slightly on the outside, knee bending to absorb some shock, and then the foot lowers itself down to the ground, becomes a floppy sack of bones to go over any uneven ground, before twisting out to become a rigid lever to push off with. That would be what we're trying to achieve for foot function. Now I spent many years, or a few years, working in a gait movement analysis laboratory at Leamington. And this was the team that I worked with, and this was the opening ceremony with Princess Anne, and we had a group of physiotherapists and occupational therapists and podiatrists there. And we used to do this, stick marker balls on our legs in order to get cameras, infrared cameras, picking up the position of those marker balls. So this is the same technology that they use for filming things like Lord of the Rings, you know, for the films where they stick the marker balls on to capture motion. From that, we then got graphs, and these graphs told us things. So this is a walking cycle from there to there. So that's from heel strike coming through to heel strike again. And a walking cycle is split at this point here, that's the swing phase of gait, and that's the stance phase of gait. It's roughly 60-40 as a percentage. So we spend 60% of the time in stance phase with our foot on the ground. And this just shows you the angle of movement at the ankle. And you get these graphs showing what the angle of movement is at an ankle joint for walking. We also had a force plate in there that told us the forces that went around the ankle. So you can imagine that when you're about to do your toe off, you're going to have a lot of force going around your ankle, and that's shown with that graph there. And we used to get graphs like this for every segment of the lower limb going down, and every view, from the side, from the front, from the back. And what did we learn from that? Well, we learned that we didn't get a lot of information at the foot because it stopped at the ankle. But nowadays, they've got a lot more marker placements, so they get a lot more data. So they understand foot function a lot more now than we did when I was working there. Okay, we've only gotten 2 marker balls there for the foot, and look how many marker balls there are now. And what it showed, we were trying to capture a normal data set so we could compare patients to this normal data set. And we hit all sorts of problems, because what is normal? So we need to take it back to school. Remember the normal distribution curve at school? And this is a distribution of the population. And the majority of the population will be sat within 1 standard deviation. Go further afield, you're within 2 standard deviations, and nearly the whole population is within 3 standard deviations. So when we're trying to find what's normal at this gait lab, and we're trying to identify what that centre point is, there's no point, because there'll be so many that are outside of that centre point. So there isn't a normal. And even more complex than that is with foot function, it shifts the normal distribution curve, different directions depending on age group, activities, genetics, things like that. So all we could conclude is there isn't a normal. Everybody is different, and everybody walks differently. And that has a massive implication for why, if you get heel pain, why isn't there a single fix for it? Because everybody's different. And that doesn't take account of the fact that all the heel pains are different, and we'll come on to that. So how do our feet function? Well, I've touched on the complexities around the movements with the directions of the collapse and the twisting out. But it gets a bit more complicated than that. I'll try and show you with a bendy foot. So we have structures underneath the sole of the foot, and we'll come to the anatomy in a little bit. But one of the key functions of the foot is something called the windlass mechanism. And the windlass mechanism is like a ratchet system using the big toe to the bends in order to spring us forwards for our push-off in gait. Okay? That windlass mechanism, is quite easy for that not to work very well because of anomalies in the way our feet function. And when that doesn't function very well, then we have to compensate for it in some way. And we compensate for it in ways that it's really hard to see when you're looking at somebody walking without the advanced techniques with the 3D analysis. Those compensations could be shorter step length, longer step length. It could be rotating and twisting out on the inside of the foot or the outside of the foot, or raising your foot up higher in order that you can actually get your legs forwards. But what it is very important to realise is it's much more complicated than just pronation. So anybody who's heard that, oh, your foot pronates, that's why you've got plantar fasciitis, just sort your pronation and you're okay, it's a lot more complicated than pronation. So let's have a look at the anatomy of the foot. The anatomy of the foot, it's a complex structure. Anybody know how many bones there are in the foot? FHPs don't answer, other podiatrists don't answer. Anybody?
Lots.
And lots. Okay, so there's 26 bones in the foot. There are sometimes extra accessory bones. And they are designed to, so we have more bones in the foot than anywhere else put together, the rest of our body, if we take off our hands and the other foot. So you think of all those bones that we have in our body all down on one small area of the foot. So it gets really complicated. And we end up with, not only the bones being complicated, we have 33 joints as well as the 26 bones. So that's a real complication when you think that your hip joint is one joint, and look at what goes wrong with the hip joint, and they replace one hip joint. With the foot, you've got 33 joints that can go wrong. And then on top of that, you've got your muscles, tendons, within the foot and coming down from the leg into the foot. You've got your nerves, your blood vessels, coming into the foot to supply it. And it's all a complex picture, and then you've got the skin on the outside. And the number of patients I get coming in and going, my foot's hurting, but I can't see anything going wrong with it. Well, how are you meant to see something on the outside when it's all this structure on the inside that really counts? So let's look at the sole of the foot. So that was the dorsum, we call it the dorsum, the top of the foot. So let's look at the sole of the foot. And the sole of the foot is really complicated. I will show you with my muscles, it's probably easier here. Here we have basically 4 layers to it, 4 layers of muscles. So I'm going to take off the plantar fascia, which is the band that runs from the heel bone to the ball of the foot. That's the plantar fascia. There. And then underneath that you have layers upon layers of different muscles as we dissect down, all the way down to the heel bone. So, why do we need all those things? Because our foot's a complicated structure. It has to propel us forwards. We've developed from the monkey traits of being able to climb trees, etc. We have to be mobile adapters and rigid levers in order to propel forwards. So looking at heel anatomy, is it any wonder that we get things like Achilles tendonitis at the back here? We get something called posterior tibialis tendonitis, there's a posterior tibial tendon there, around here. We get tarsal tunnel syndrome here. We get our fat pad issues here, and there's the plantar fascia just there. So when somebody comes with heel pain, it could be any of these structures that could be causing problems, not just the plantar fascia. It could be any of these muscles that insert into the heel bone that could be the difficulty for them, not just the plantar fascia. So deep understanding of anatomy is really crucial. On top of that, you've got the nerves that come down here, and they can get irritated in this area, and you can feel pain underneath the heel here. And that can happen all the way from the spine, that you actually get heel pain because you've got a lower back problem. So is it really plantar fasciitis? Everybody knows it as plantar fasciitis. I don't know why it's come around as that, because we were talking about this last night with a group of podiatrists. Go back years ago, we didn't know plantar fasciitis. We didn't have that as a label. We called it what it was, which was if it was an insertion, if it was pain at the insertion into the heel bone, we called it an enthesitis, because that's where the emphasis is. It's a medical term. The plantar fasciitis could be anywhere along its length, but over time, it's kind of come back and saying anything that inserts underneath the heel bone there that's painful is plantar fasciitis. But they're not all plantar fasciitis. So we've covered function, we've covered anatomy. Let's look at the pain. So it's not plantar fasciitis, we refer to it nowadays as plantar heel pain, because that just describes what somebody presents with in order that we can then get the diagnosis. But what is pain? So I'm going to play a video here that really does explain very well what we understand about pain now than what we understood about pain maybe 10 years ago. And it really has moved on a lot. And then And they've worked out that it's not about so much what's going on down there, and I'll show you now.
Everyone agrees that pain is a universal human experience. We now know that pain is 100% of the time produced by the brain. This includes all pain, no matter how it feels, sharp, dull, strong or mild, and no matter how long you've had it. You might have had it for a few weeks or months. This is called acute pain, and it's common with tissue damage, say from a back injury or ankle sprain. And generally, you'll be encouraged to stay active and gradually get back to doing all your normal things, including work. Or you might have had it for 3 months or more, and this pain is generally called persistent or chronic, because in this type of pain, tissue damage is not the main issue. What's less clear though is when you're told you have chronic pain, is knowing what's best to do about it. Well, in Australia, chronic pain is a really big problem. In fact, 1 in 5 people have it. Having a brain that keeps on producing pain, even after the body tissues are restored and out of danger, is no fun. Some people say it still feels like they must have something wrong. But that's just it. Once anything dangerous is ruled out, health professionals can explain that most things in the body are healed as well as they can be by 3 to 6 months. So ongoing pain being produced by the brain is less about structural changes in the body and more about the sensitivity of the nervous system. In other words, it's more complex. So to try and figure out what's going on, you need to retrain the brain and nervous system. To do this, it's helpful to look at all the things that affect the nervous system and may be contributing to your individual pain experience. What can help is to look at persistent pain from a broad perspective, and by using a structured approach and a plan, it's less likely that anything important will be missed. Let's start with the medical side. Firstly, taking medication can help, but only to a limited extent. It is the more active approaches that are necessary to retrain the brain. So using medications to get going is okay, and then mostly they can be tapered and ceased. Some people also think surgery might be the answer, but when it comes to a complex problem like chronic pain, surgery may not be helpful. So if you're thinking of surgery, it's best to get a second opinion, and remember to consider all the things. Next, it is helpful to consider how your thoughts and emotions are affecting your nervous system. Pain really impacts on people's lives, and this can have a big effect on your mood and stress levels. All those thoughts and beliefs are brain impulses too, but you can learn ways to reduce stress and wind down the nervous system. This helps with emotional well-being and can reduce pain as well. The third area to consider is the role of diet and lifestyle. Now, it turns out that our modern lifestyle might not be so good for us. In fact, what we eat and how we live may really be contributing to a sensitized nervous system. Looking at all the things like smoking, nutrition, alcohol, and activity levels, and seeing if there are any issues is a good beginning, and these things can go on your plan. Then there's often enormous value in exploring the deeper meaning of pain and the surrounding personal story. By stepping back and looking at all the things that were happening around the time the pain developed, many people with pain can make useful links between a worrying period of life and a worsening pain picture. For many, recognizing deeper emotions can be part of the healing process. Last, but by no means least, is physical activity and function. From the brain's perspective, getting moving at comfortable levels without fear and where the brain does not protect by pain is best, and you'll gradually restore your body's tissues. So, to sum up pain, it comes from the brain and it can be retrained, and when looked at from a whole person or broad perspective, gives you a lot of opportunities to begin. So, get a helping hand if you need it, set a goal, and begin.
So that's the complexity of pain. So we've got this plantar heel pain, this specific problem, but actually what's going on might actually be more up here than down there. So we talk about the biopsychosocial aspects of pain. It's a model of pain. And it's basically whereby we get caught up in this loop over here rather than actually getting resolution over here. And a lot of it comes from the fact of where we catastrophize the pain. We actually say to ourselves, something's broken, something's going wrong, I can't put load on it, I can't use it. Or you go and see somebody who says that you've got, you pronate too much and that's what your problem is, and until you get that fixed then it's going to stay there. Or you've got a real fear around pain, maybe it stopped you from doing something significant in your life, and it can really hold you back from recovery, as opposed to coming through this side where you're not fearful of the pain experience and you get all the way to recovery. So this is the biopsychosocial. We look at the biological, biomedical around here, the social side and the psychological side. I'm not going to cover these today, but they are massive things for us to consider as therapists when we're dealing with patients with pain. It isn't just about fixing the biology. And anybody who comes in with chronic pain, this is what they'll get from me trying to work with all of that rather than just that, because it's so important. When it's acute damage, then yes, you can probably do it there. But when it's chronic, then we're looking at all of this. So this is a flowchart for what's your heel pain. And it's something that you can, one of my colleagues put together, that you can work your way through using yes and no answers in order to work out some very basic things around heel pain. We've turned that into something really useful. So if you've got your phones and you want to go onto our Facebook page and send us a message, you'll pick up a chatbot, and the chatbot is programmed with that flowchart in there. So you can answer the questions and it will actually come up with the answer according to that flowchart. But it's a very simple way, simplistic way of understanding heel pain. For you, and it may not go enough in depth, but it'll give you a guide. But I'm going to run through some of those things now. Okay. Let's look at extrinsic causes of heel pain. So these are the things outside of the body, something that could be having an effect. One of the things is things inside shoes. You could have a stone or a splinter or a drawing pin sticking up through the sole of the foot, and that could be causing you heel pain. Your inside shoes could wear out. One of the structures of the heel counter in the shoe these days is that in order to make them lightweight and easy to mass produce, they do a honeycomb type structure underneath, and that can break down and degrade, and that can cause heel pain. Wearing footwear that isn't necessarily the best for your foot can cause problems. This one, you can see how it overloads the ball of the foot quite easily, and it tips the heel into an angle it was never designed to work at, because if it was designed to be like that, wouldn't we be being built like that? Yeah? Yet we'll put it into footwear like this, or even less of the heel, and can invite problems with the heel pain. Then there's superficial causes. And this is an article I picked up, but I have seen lots of superficial causes of heel pain, predominantly hairdressers, because they cut their hair all the time so hair can get in there, and animal owners, dog owners particularly, you get hairs in there. I've had a patient recently, he's a dairy farmer, it wasn't heel pain, he actually got lots of cow hair in space in between his toes, and it actually impregnated into his flesh and caused a little cyst in his flesh. And over a period of a few weeks we've been pulling out hair after hair after hair, and now it's healed. So these things do get into our tissues and can cause pain. Anybody know what that is? Verruca, yes. So verrucas can be painful, and they can be on the heel. So you could have a heel pain because of something on the outside, the superficial area. And that, there, it's a corn. Okay? And a corn, it can be painful on the heel because it feels like you're walking on a stone. And a heel crack or a heel fissure can be painful. So these are the external things that we have to exclude when we're looking at heel pain. And sometimes it will be something as simple as one of those. It could be fungal infection causing more dryness and splitting on one foot than another foot. It could be scarring. Somebody's had an operation here on their Achilles tendon, and that can cause ongoing pain afterwards. And they'll describe that as heel pain. Sorry about the pictures if you're not into feet. Don't know if you can quite see these little white lumps here. Pietzogenic fat papules. Not generally painful, but they can be uncomfortable, and it's just micro herniation. So you know when you get a hernia, you get a muscle pushing out through another muscle. This is a fat pad herniation through the tissues. Or it could be an infection from a cut on the heel, spreading beyond the heel, causing problems. Or one of the things that's really common in around the world are pressure sores. Yeah, this is a grade 1 pressure sore. Somebody lying in bed, and their pressure, their weight of their body or their foot on the mattress is more than the vessels have pressure to sustain life within that tissue. So it literally starts to die, and over time it dies more and more and becomes a full-blown pressure sore. And these are probably a comprehensive list, and there may be a few cut off there, missing from there, for plantar heel pain that isn't any of those that I've already covered. And patients can come in with any of these things that's causing their heel pain. Commonly, what we'll see is fat pad atrophy. Yeah, we're meant to have a decent fat pad on our heels. As we get older, it can atrophy. If you have steroid injections, it can atrophy. That can contribute to your heel pain. Posterior tibial tendonitis will be something that we see that people think is plantar fasciitis, but it's completely different tissue and it's dealt with in a completely different way. Achilles tendonitis, pain at the back of the heel, isn't the same as pain underneath the heel. We can have up here, the calcaneal stress fracture or the calcaneal bone stress reaction, which is basically our heel bone has the plantar fascia pulling against there as well as all the muscles, and it has the Achilles tendon pulling there. So that heel bone being pulled apart, that can irritate the heel bone, as well as the impact forces as you hit the ground can cause irritation to the bone structure. And that, let me just go back a second, and that will cause inflammation in the bone. And very often I'll see patients who are busy stretching the plantar fasciitis because that's what they've been told to do, stretch the plantar fascia, and they're causing more damage to their irritated bone because it's pulling on that bone stress reaction. So it's really important to get that diagnosis right. So if we go back to those 101 Dalmatians, we're all different. Our anatomy on the whole is the same. There are some differences, but there's a whole load of conditions. Can you see why there isn't a one fix for it all? Because there's not a single diagnosis. So when you ask people, and this is particularly going into the Plantar Fasciitis UK forum, people go on, what do you do about your plantar fasciitis? And everybody goes, well, I tried this and it didn't work, or I tried that and it did work. They could be dealing with any one of these conditions that they're describing their solution for, and that's why it might work for one person, not somebody else. Or their whole makeup, of their Dalmatian makeup, could be different to the other person. And that's why it has to be done on an individual basis, because there is not one generic plantar heel pain, this is all you do and it's fixed. So, who would you first ask for help with heel pain? This is audience participation time. So I want you to shout out, can I just squeeze in this? I want you to shout out, who would you first ask for help with heel pain?
GP.
GP?
Physio.
Physio.
Podiatrist. Google it.
Dr. Google. Anybody else? Anybody seen osteopath or chiropractor with heel pain? Would you? No?
No.
Pardon? You have? What about sports massage therapist? Anybody see somebody like that maybe with heel pain? Yeah? about an acupuncturist? Maybe?
Yeah, possibly.
Flexologist?
Yeah.
Pharmacist.
Run out of space, so can't do too many more. Apologies for my doctor writing, by the way. Anybody else? Anything? Anybody else who might be asked about heel pain? If we've got some in the audience here. Foot health professionals, you might get asked about heel pain. Or friends and family. People ask their friends and family, what do I do with my heel pain? Yeah? So a whole mix of people there that you could ask. Now bear in mind we've identified there's lots of different diagnoses and lots of differences in human gait and how we walk. So which of those do you think could accurately diagnose the condition? So I want you to tell me if I'm going to put a tick for diagnosis or not from these. Do you think a GP could accurately diagnose it? Oh.
No.
Physio? Maybe some
Possibly.
people. Okay. Podiatrist?
Yeah.
Hope so.
You'd hope so, wouldn't you? Dr. Google?
No.
Osteopath?
Possibly.
Possibly.
Chiropractor? Not so sure still?
Possible.
Sports massage therapist?
No.
Acupuncturist?
No.
Reflexologist? Pharmacist? FHPs?
Yeah.
No insult to you guys. Would you? The diagnosis?
No, possibly not, no.
I'll put
I'd
question
refer
mark.
on.
Friends and family?
No.
Okay, so that's brought us down to a few. Okay, so we've taken out the GP. Yeah, where does everybody go with the heel pain first of all? Go to the GP. GP training for heel pain?
No.
Tiny. That's why they'll only give you the diagnosis of plantar fasciitis, because they haven't got any understanding of all those diagnoses, all those possible diagnoses. They'll have some understanding of them, but they don't have the time to spend to get to the bottom of the diagnosis. It's not a quick thing. You don't just walk in and go, I've got heel pain, and I go, oh, it's that. There's a whole load of assessment that has to go into that in order to get to that diagnosis. Physio, yeah, there's some good physios out there who may have more understanding of some of those conditions, and the same with osteopaths or chiropractors. But the places that people end up going, when they end up coming to me, is they've been there. That's their first port of call. And they do that for about 3 to 6 months before they come in. 3 to 6 months of pain, trying to get a solution for something that neither of those can diagnose fully for them. And they go there, and I'm going to cover with you what happens when they go there. So first of all, they might go and get referred for an X-ray. And this is why this question, to scan or not to scan, that is the question. And bear in mind that all those soft tissues underneath that heel bone are all soft tissues and don't show up on X-ray. What's the point of going for an X-ray in the first instance? Because that's where the GP will often send you. And they go because they're trying to look for a heel spur. But lots of us will have heel spur. Those in the room who don't have plantar fasciitis could have heel spur. It's a common thing to occur and it isn't linked necessarily to plantar fasciitis. But you go for the X-ray and it says you've got a heel spur, and they say, oh, then you've got a heel spur, that's what your problem is. And it's not true. They've proved that it's not true like that. So an X-ray really isn't necessarily the first port of call for plantar heel pain. An ultrasound scan may be more appropriate, but an ultrasound scan can't look at the bone, it can only look at the soft tissue. This is, let me get the angle. This bone here is the heel bone, like that, okay? And this plantar fascia is it coming to insert into the heel bone. And they measure the thickness of the plantar fascia. And from that thickness, they could ascertain whether there's inflammation, damage, thickening of the plantar fascia and whether it needs to be treated. The problem of scanning your heel pain as your diagnostic tool on its own is that you could just have a thickened plantar fascia. like you could have a heel spur, and it may not be the cause of the symptoms. You could go more in depth and you can have different MRI scans on the tissues to look for inflammation and problems. But bear in mind we said about the biopsychosocial aspects. How's this lot looking at what's going on in your life and how you're dealing with pain? So scanning isn't necessarily the first port of call. It's certainly if you're not responding to the treatments for the diagnosis that somebody who's specialised might come up with, then yes, we would tend to refer on for a scan at that point. If it's not fitting into a typical pattern for one of those diagnoses, then yes, we might refer on for scans. But first port of call would be to see somebody who understands all the diagnoses and can actually come up with the working diagnosis that they can start a treatment plan and see how it goes for you, or refer on if necessary. And diagnosis starts with history. It's the absolute most important thing is for us to map the journey of your pain. When did it start? What were you doing at that point? What were you doing before you developed pain? Because that will really give us an indication as to the diagnosis of the problem. Yeah? If somebody said that they'd been digging in the garden, it was spring, they'd been in spring, digging in the garden lots, and they got pain in the sole of their foot or underneath their heel then you can think, well, yes, that was a traumatic injury to the heel. Doesn't necessarily mean it's plantar fasciitis injury, could be something else. But at least you know it's likely to be a traumatic injury to the heel. As opposed to somebody who said it just came on gradually. Even more important about the history is looking to see whether it's one foot or both feet. Because it's really, really unusual if it's a localised problem in the foot for it to be exactly the same in both feet. It's more likely to be coming from somewhere else for it to be exactly the same in both feet. So getting the good history. So we'll spend, if somebody comes to see me, I'll spend a long time talking to them about their story, their journey with their pain, rather than just jumping in to a treatment. So what treatments are possible for plantar fasciitis, for heel pain? Anybody who's had it or anybody who knows anybody who's had it can shout out any treatments. Okay?
One day I had a steroid injection.
Steroid injection, that's a common thing, yes.
Exercise.
Exercise. Or any particular sort of exercise?
Stretching.
Stretching, yeah. Anything else?
Rolling your foot over a bottle of ice.
Rolling over the ice bottle, yeah.
Strapping.
Strapping. Anything else?
Yeah, I've got a little round, pointy, rolly ball thing.
Oh yeah, the spiky ball. Yeah, spiky ball. Orthotics, insoles.
Oh yeah,
Yeah.
I've
Got those, yeah. Strengthening. Yeah. Shockwave. Anybody heard of shockwave?
About to start.
Laser therapy. We'll come on to in a bit. Lots of different possible things. The ideal treatment plan is one that takes you from where you are with pain on a road to recovery to resolution there. And there isn't the quick fix that does that. Generally, if it does that, it's going to come back down the other side, and that's part of the problem with the steroid injection, that you can have that quick fix and then it just comes back down. Yeah? And really you want to be moving on stage to stage to stage. Unfortunately, recovery is never in a straight line. It's always like this. And you end up going, oh, that's working. Oh no, it isn't. It's going bad again. Oh, I've got to change treatment. Yeah, and you need to be guided in that, and it all comes back to that diagnosis, because what gets you from there to stage one for one diagnosis might be different for another diagnosis. So the general things that we talk about used to be rest, ice compression elevation, RICE therapy. It got superseded with PRICE therapy, so that's protection, rest, ice compression and elevation. It then moved on to police therapy, where we protect and we offload or do optimal loading, ice compression and elevation. The problem with these is this is really applicable to the acute phases. And very often with plantar fasciitis or plantar heel pain, it becomes a chronic problem. Yeah? And we don't necessarily refer to it as plantar fasciitis, it's used the term as plantar fasciopathy or plantar fasciosis. That's why we end up with plantar heel pain, because it just describes all of them. So nowadays, we'd be looking more at peace and love. And this is more in the acute stage, and this would be more in the, where we're trying to move it on from there. Okay? lots of treatments will fit into the different stages of these interventions. So let's have a look what the NHS recommends. So NICE is a government body that says what the GPs and other healthcare professionals should really be doing for the care of conditions. And there are NICE guidelines for plantar fasciitis, and you can look these up on the internet, okay? So you can see what should be happening according to the NHS. But these were written in 2015, yeah? Things move on, and they move on quite quickly in healthcare, so they may well be out of date. They need to be reviewed at the moment. All these QR codes, if you want to, you can scan them in if you want to on your phones. So this is what a NICE guideline says, that the self-care advice should a GP give to a person with plantar fasciitis, because this is what they'll be following. And it will talk about rest, we talk about rest therapy, anti-inflammatories there, losing weight here, applying ice, and using heel pads, okay? And what advice should I give about self-physiotherapy? Well, it talks about stretch, stretch, stretch and stretch. Okay? That's what the NICE guidelines are. So it's all about take the load off to start with, and then you just stretch, and you do lots of stretching. And when should I consider a corticosteroid injection? And there's guidelines for when you should be considering that. And generally, they'll say the doctor might have a go at doing the steroid injection, or we might refer on for you to have it done. I hear all sorts of horror stories of steroid injection. Did you say you'd had a steroid injection?
Monday.
Did they go in the sole of the foot?
Yeah.
Painful?
Right in heel.
Yeah, was
Yeah,
it painful?
I've got it in that foot, but that's cured.
Yeah.
It's just coming this foot.
Yeah, but when they did the injection, was it painful, or were you okay?
Put a freeze spray on it.
Oh, they did put a bit of freeze spray on. Okay. So I'm going to show you a video. If you don't like needles, then please look away. Okay. But I'm going to show you a video here of how it doesn't have to be a painful injection. So this is me.
The injection of the steroid. We're going to go in where we've just put the local anaesthetic. It's a bigger needle, so the patient shouldn't feel this as it's going in.
No.
Nice and comfortable. We go in to the plantar fascia, insertion into the calcaneum, trying to find the hot spot for the patient.
What's the hot spot?
Where the centre of the inflammation is, because you can get a lot of dissipation of pain around from that centre.
Okay, so we're going to take that as the hot spot now, and we're going to push the steroid into the foot.
Steroids like an emulsion, it's like a powder in the solution, and it's quite hard to push it into the tissues.
And it's in. Comfortable procedure.
Yes.
Pull that out.
So that's the steroid injection. Steroid injection, it's very often used, particularly in NHS care, as that quick fix trying to just get you out the door. Yeah? That seems to be the process with steroid injection, rather than getting you on a treatment plan to get to full recovery. They'll give you your exercise sheet, they'll give you a steroid injection, and away you go, and I'm sure you'll testify to that. But it doesn't always work. So when should GP says, refer a patient with plantar heel pain to podiatric physiotherapy or orthopaedic surgeon? Well, it says here that refer people with mild symptoms to a podiatrist or physiotherapist if their self-care has not been effective after a few months. So you have to suffer for a few months before you get referred to anybody who might know what they're doing with heel pain. And that referral is only really if it's in the more severe stages. And from there, if you've seen the podiatrist, the physio, and it hasn't worked, then you get referred to an orthopaedic surgeon. And to get at the orthopaedic surgeon stage, it says that's when you get your shockwave. Your shockwave is one of the potentially better treatments to deliver earlier rather than later, yeah, as a potential intervention. Or you can have surgery and they either work on the plantar fascia or they can work on the calf itself to release tension. The purpose of the referral is so that the physio or the podiatrist can hold your hand with your advice on what you've got to do for your exercises. Ensure that you're stretching, all about stretching they're saying, and check the suitability of your orthotics and your footwear, and maybe do some custom made ones, and maybe do some taping and night splints. These are the NHS guidelines for the care of plantar heel pain. And this thing about custom-made orthotics, and you see it everywhere, these big claims about how it's going to realign your body. And you put them in your shoes and it stops the pronation and everything's fixed and everybody's really healthy because they're wearing custom orthotics. But there's no research to suggest that custom orthotics are better than off-the-shelf orthotic, and there's nothing necessarily to say that you need to be in orthotics long term. It may just be a temporary crux to support your foot in order to get it better. So this is me fitting orthotics, and there's some examples of orthotics around here. I'll show you, I'll pass around in a second. And it used to be thought that what we did was we got these feet that collapse down. You can see they're collapsed with these heel bones that are just tilted inwards. And we'd stick an orthotic in and suddenly they magically straighten up, and you'll see all the advertising on orthotics is around that. Well, here's somebody who's got that collapse, and he's got the angles going just like that last drawing, and here they are in orthotics. And it's no different, is it? Orthotics don't realign. Okay? The foot orthoses, what they do is they change the forces around the foot to reduce the strain on the tissues, not a realignment. I'll pass these around so you can have a look at them. There's all sorts of different types. And this is the type you might get if you had a custom-made orthotic, and it's made of a rigid shell with a softer top cover with whatever redirectional forcing posts on there to change the forces in the tissues. But interestingly, there's an off-the-shelf one that looks very similar to it. This came out a few years ago, and this I get on very well with as an orthotic for patients. You can also go with slimmer profile to fit inside the shoes more, but then you're compromising prescriptions. You can go with even slimmer ones to fit inside court shoes. You can go with different densities of material, so this is a soft one if somebody needs to have more cushioning underneath the heel. And you can go with heat mouldable ones that actually we don't send off to a laboratory to get made, we actually get them, we do them in clinic. And these days you can get 3D printed ones as well. So all sorts of different types, but what they don't do is they don't do that. Okay? So it's not as straightforward to get a prescription to go, okay, I'll go to Boots, which is the advice you might get, go to pharmacist and get your insole. How do you know what forces need altering and what your diagnosis was in order to what tissues you need to offload? And tissue healing is complex. Really complex. I'm not even going to try and explain it all to you, but these key words in here really show you what takes place as far as tendon repair is concerned. There's a whole complex process to get us to heal our tissues. So I'm going to go for a simpler version, and we're going to talk about zoos. This is the zone of optimal stress. And if we look at this as our graph for the zone of optimal stress, and the easiest way I explain this to patients is that we have a zone of optimal stress for a particular tissue. When we're young, that zone of optimal stress tends to be quite big. It takes a lot for us to damage our tissues. As we get older or we have certain medical conditions, that zone might get smaller and smaller. On the one side of that zone is damage, inflammation, irritation to the tissues. On the other side of that zone is degeneration and weakness because you're not using it enough. So we need our bodies to function within that zone of optimal stress. When we have a painful, noxious stimulus, then it closes that right down and we end up over in this pain area of inflammation and pain, or at the end of degeneration and weakness. And so the key part is to keep our bodies within that zone of optimal stress, and by identifying what that is for a patient and getting them to stay in that zone of optimal stress, then they can make recovery. Now this applies very much to tendons. A lot of the research is around tendons, but the plantar fascia is a classed as ligament, but it acts like a tendon, so it does apply in this situation. And this is where load management is the key. So I do some mountain walking and take my son with me, and in this spring, summer, we did Mount Tidy in Tenerife, which is 12,500 feet or something. And we had to get to the top of this, the highest point in Spain, although it's on Tenerife. In order to do that, we had to make sure we were prepared and able to cope with getting up to the altitude, and it's hard to prepare for altitude with our low-level existence here. So we couldn't train from the point of view of cardiovascular necessarily for the lack of oxygen, but we could do some hikes to make sure we were fit to do it. But what we couldn't do was suddenly stick a big rucksack on our backs and decide that we were going to do it, because we hadn't trained with big rucksacks on our backs. A couple of years ago, I went to Everest Base Camp with a group of podiatrists, and this is Pod 6 Feet, we were promoting podiatry, and we went to Everest Base Camp. And again, we trained as best we could. We didn't carry loads of load with us because we had Sherpas. And we had a Sherpa like this. And this Sherpa, he was tutty and he was slim and he was tiny. No way should he be able to carry this as a load. This is 2 lots of kit, 2 people's kit on his back at once. Yeah? And these were 20 kilos, so he's carrying about 40 kilos on his back, and he's trekking with us, and we're struggling to get here. It's not easy, and he's doing it, but he's grown up doing it. His body's used to it. That's what he does. All his bones and muscles and tissues and his oxygen use is all designed. He's developed that over the years. And there's ones that carry this sort of stuff, and they do it day in, day out. That's what they're used to. If we tried to carry that, we would cause damage to our tissues. And what happens in our existence is we sit down and we're sedentary a lot of the time. We sat in our cars, we sat at the offices, in our offices, and then suddenly at the weekend we'll decide we're going to go and do something, yeah? And we'll suddenly have a spike of load, and that's when we cause damage. In the spring we'll get out in the garden, we'll start digging in the garden, we'll climb ladders, or we'll buy different shoes and we'll think it's okay. I had a patient today come in. He could come in last week with a plantar heel pain problem. I strapped him up. He had 5 days, absolutely bliss, no pain whatsoever. So on the 6th day, he said, I'll test out how good it is. And he went walking all day yesterday, yeah? Well, of course, it's not going to fix in 5 days. It's a complex process, yeah? And he's back to square one, because you have to do that load management gradually to get him back to full function. Anybody know who this is? Arnie. It is Arnie, you're right. So Arnie, at this age, started taking up his weight training, didn't he? Yeah? And over time, he laid down new cells, new muscle tissue, new stronger tendons by putting ever-increasing load through his body. He couldn't lift the weight he could do then, when he was that age. He had to work up for it, because if he tried to lift the weights he did then, what would happen? He'd damage his tissue, wouldn't he? Yeah? So he had to progress slowly. And that's why you'll get exercises given you that ideally take you through from injury to return to activity. And yet very often, and those NHS guidelines, what did they say? Stretch, stretch, stretch. Was there one single mention of strength in that advice? There wasn't. And yet we know that actually putting a tendon under ever-increasing, gradually increasing load in terms of intensity, volume and frequency, and working it up in different ways to get you all the way up to there. And that's not just doing one single exercise in one single way. It's coming up with an individualised treatment plan that will support your structures so that they actually repair themselves, so you get better quality cells laid down, stronger tissues to enable you to return to whatever activity you want to do. It isn't just about doing heel races. So why Pods, Heels, Heels? So you're in the middle of a 2-week national campaign at the moment that's taking place to promote podiatry as the place to go to with heel pain. Not because we've got the magic, not because we can fix every single heel pain, but because we can get you on a path that will try and fix your heel pain for you, that makes more sense for you as an individual, getting your diagnosis right, doing the in-depth assessment, accurate diagnosis, and an individualised treatment plan. And when we look at what that can, why podiatrists? So they can do the in-depth assessment. We've got practice interview skills. We're used to dealing with lots of patients. Our training involves a lot of hours with patients and understanding history taking and motivational interview skills. So we actually get you on board with your treatment plan. We've got an awareness of red flags, so things that might be cropping up that could be going wrong. We talk about zebras and horses. So horses are common and zebras are rare. We've got to be aware of the rare things, but most often the time we're dealing with the horses. We have an in-depth knowledge of anatomy and biomechanics. Biomechanics is how our tissues work, how we move. We do accurate diagnosis. We've got the longest training in foot pathologies of all those that we've written down here. We only train in foot and foot-related structures. We've got knowledge of physiology and medicine, and we've got an understanding of all those differential diagnoses and the impacts that it can have. And then the individualised treatment, we're used to designing treatment plans for our patients with multiple tools in the toolbox, including maybe shockwave, laser therapy, both low level and high intensity laser therapy, strapping, mobilisations, manipulations, the orthotics off the shelf, over the counter and bespoke, steroid injections, access to prescription only medicines and rehabilitation programs, and some of us do acupuncture. I don't do acupuncture, but some do. So that's a lot that can help you with your heel pain, yeah? Whatever the diagnosis is. But what is a podiatrist? What do you think podiatrists do? Feet, yeah, okay. What do we do? What conditions do we treat?
Pain.
Pain, yeah.
Just foot condition.
Any foot conditions, yeah. So we have an identity crisis because a lot of people don't think of podiatrists as the first port to come to with a foot problem, even though we treat foot conditions. Yeah, they end up going to their GP, they end up going to anybody else on the list. But if you have a tooth problem, where do you go? You go to the dentist. You don't go to the doctor, you don't go to the pharmacist, you don't go to the beautician with a tooth problem, you go to the dentist. And this is why we're doing the pod sales is to raise awareness that actually, if you've got a foot pain, then go and see the podiatrist, get the diagnosis there. We may refer on, there may be people who can perfectly adequately look after it. It doesn't necessarily mean that it has to be podiatry looking after it, but if you've got pain, then maybe go and see the podiatrist to get that looked at. And I actually wrote a lengthy blog on the differences between all the people who look after feet, because it's not straightforward. And it's for those who have read it, Chris, I think you've read it, haven't you? Yeah, it's an eye-opener, isn't it? Yeah, as to the legalities around treatment of foot-related problems. And it's just a bit titled on just title differences there. So you can grab these up, put them back up at the end if you want to, if you want them. So podiatry really is much broader than just what a lot of people might think that maybe it's just nails, corns, verrucas, things like that. Podiatry is now a 3 to 4 year degree program, okay, with access to medicine, POMS, prescription only medicines. You can go on and do masters. Dave in the corner here is a podiatrist who's got his master's degree. You can get a PhD, you can do supplemental prescribing, you can do independent prescribing, and you can extend your scope of practice in all sorts of ways, and of course you can get lots of experience. And I put this together to really show what podiatry can be. You've got in-depth assessment and diagnosis. We look after high-risk feet, diabetes and poor circulation. Look at the ones with joint diseases or skin problems, musculoskeletal problems, the biomechanics, what we're talking about here. And then you can do surgery and injections. And then you've got the chiropody, the old-fashioned chiropody, foot care and aesthetics over here. And each one, then we can go down from. So doing in-depth medical history. We can do things like Doppler assessments and thermal scanning. We can look at the neurology of a situation. Sometimes your heel pain may be related to the nerves, as I said, and we can actually start to look at that. We've got all sorts of tools that we can use in our assessments in order to get closer to the right diagnosis, including ultrasound, X-ray and MRI. I don't have these in my clinic, but I can refer on if necessary. For high-risk feet, we look at risk status and we give lots of advice, looking at insoles and footwear modifications and management of ulcers. It's not a diabetes talk, this plugs into a diabetes talk. And we also do that referral onwards and liaison with other healthcare professionals. So as we go down each of these, we'll see there's lots of treatment options that we get involved with. for different conditions. But I'm going to come to this one here because this is the one about the plantar heel pain. So this is we're able to look to see whether your foot and leg pains are coming from locally or whether it's something more systemic going on, whether it's a referred pain from the low back, for instance. We'll look at the tissues as to what particular tissues down, bearing in mind all that complex anatomy that we talked about. And then we'll look at the different interventions that could help you, and not just giving you a sheet of exercises and a steroid injection. Yeah, because it's got to be individual to you. I'll skip through some of these so we can do the steroid injections as you've seen me shown there. And not every podiatrist can do all these things, but a lot can. And they're just developing skin surgery for podiatrists. We do nail surgery, but they're actually developing skin surgery for us. And then you've got your foot care, which is with the foot health professionals come in, and they are offering some of these things over here. Yeah. So this is what I offer at my practice, other than the things in black, but I refer on for those if necessary. So it's a comprehensive podiatry service. We also have virtual podiatrists on our website, whereby you can go on, you can find out some information, some sheets. So if you've got pain in a specific area, it'll show you some of the differential diagnoses. And there's help all around the UK with this. There's lots of podiatrists all around the UK who can help with plantar fasciitis. And there's lots of sufferers. So this is the group we're streaming to at the moment. Hopefully we've still got battery power with these 6,000 people who are suffering plantar fasciitis. Yeah, and they're all seeking that magic solution. Those who've got the problem today, you came here hoping I'd give you a magic solution to say this, just do this. But I hope you realise how complicated it is, and how it's not straightforward just to give you that bit of magic. But certainly the magic you might have had from other professionals isn't necessarily all the things that you could have to help you. And one thing that happens very often is that people see a podiatrist, they don't fix the problem, and they give up on podiatry. So if you had a bad haircut, this doesn't apply to me obviously, but if you had a bad haircut, what would you do? You'd go to another hairdresser, wouldn't you? You wouldn't give up on hairdressers. You wouldn't suddenly ask your butcher to start cutting your hair for you. You'd go to another hairdresser. So it's the same with getting help with your foot problem. If you've identified podiatrist as the best place to go, but the one you might have seen hasn't been able to solve your problem, don't just give up on podiatry. Find one that could help you with your problem. The same way, if you want your hair sorted the way you want it, then find the one that does that for you. So let's bring that back to Evan's robot bear now, because this is quite important, because we said how complicated walking is. Yeah. So Evan and I have a great relationship, if not heated a little bit. He's approaching teenagehood now. Yeah. And of course he kind of thought maybe he knew a fair bit about walking until he actually talked to me about it, and I said to explain to him how complex it was, and he ended up putting his robot on wheels. Because it is complicated. So, sorry I haven't got the magic for you. There's a lot of information that you can access for free though that might be helpful there, okay? And you can certainly get in touch with us at the clinic and we'll do whatever we can to help. But there isn't that, just take that and it'll just be fixed. It's a slow process. The two things I mentioned quite quickly there was shockwave and laser therapy. So shockwave is something that's gained a lot of ground in recent times. And does anybody know what shockwave is?
No.
Okay, so yeah.
There's a thing online, because I'll try anything.
Yeah.
And you strap it and it's sending, it's plantar cure it's called.
Okay.
And that's sending shockwaves through.
Yeah, so the amount of shock from something like that would be minimal, but it can change the pain relationship for you, so that has an effect on the psychosocial, you see.
It's a therapeutic vibration, but it will work for some.
Yeah.
Yeah. Well, I was
So real shockwave,
yeah.
real shockwaves like a pneumatic drill hitting into the tissues, yeah, and causing pain. And there's some debate about how it's working, because some of them talked about the cavitation of the tissues, so actually this air bubble going through the tissues that actually sort of burst and cause microtrauma. And then there's others that say actually you feeling a pain stimulates, wakes your body up and says it's hurting, come on, you need to get fixed now. Yeah. Sorry to put you off there.
Thank
Okay?
you. That's what the doctor says, is sometimes it's just not healing,
Yeah.
and your body's forgotten about it.
Exactly,
And it
yeah.
reawakes that healing
Exactly.
process.
So
I listened, you didn't.
Yeah, no, he started
And there's a-
laughing.
there's
He
a lot
said,
of-
he's
there
going
is-
to slap your foot with a paddle.
Yeah. There's a lot of research to support shockwave, okay, to suggest that it is useful if the diagnosis is right and the stages of healing are right. So if you've got into chronic and you're not going anywhere and you're not progressing, it is a good one to kickstart. But if you're progressing and you're on the road to healing, then there's no necessarily that you have to go in with shockwave. And this is where laser therapy comes in for me, because laser therapy is actually a stimulus to encourage good healing, but it hasn't entered mainstream healthcare yet. It used to be low-level laser therapy going back many years, but the results were very hit and miss. But you'll find some research around low-level laser therapy. High-level laser therapy is a newer modality brought in from veterinary world, and that seems to be having some really good results, but it hasn't reached the research level to be getting into these NHS guidelines. It won't, I don't think it'll make the next batch, but another 5 years' time I think you'll start to see it appearing, because it really does make a difference to the tissues. And I've got my laser therapy unit down here. It's a really simple unit that we use, and it's non-painful.
How does that work?
Okay, so I'm not an expert in understanding how it works. So the simplest explanation I can give is that, you know, when we, on a sunny day, we all feel happy and healthy, yeah? So imagine if you can take that and put it down into a cellular level, yeah, just right into the cells. So taking the good bits of sunlight, putting them into the cells, and each of the cells felt better, yeah? So it's doing that, it gets into the ATP within the cells and energises the cells basically, so they can function better or repair better, basically. But you've got to get the right setting for the patient to actually have the effect that you want. But the difficulty we have, it'd be really good if you could do these rehab programs and treatments with patients, and then for the rest of the time they didn't do anything until they did their rehab and then didn't do anything. But what happens is that people do the rehab and then they go, oh, I've got to go and do a walk now, yeah? Oh, I've got to go and do that job, I want to do the digging in the garden or whatever, I want to wear that pair of shoes. So you traumatise it again and it comes back downhill. So that's why it's a complex thing. It isn't a magic thing to suddenly say, have laser therapy, you're going to be better, or have shockwave, you're going to be better. It needs to be part of a whole treatment plan, and I think this is where it falls apart for me under a lot of NHS care, not all NHS areas, but a lot of NHS care, is they're only taking you in isolation for that one treatment. So you go to them for your orthotics, yeah? And you don't have any of the stuff around the progressive loading and the strength work, for instance. Or you go to them for your shockwave, yeah? But you have your shockwave after you've had a steroid injection. And they're two different treatment modalities. The one's trying to damp down inflammation, and the other's trying to get it going again. And it's because we're coming from a process that the NHS can't cope with, because you see the doctor first and he'll try something, then you'll see the physio next and they'll try something, then you see the podiatrist next, they'll try something, then you get into the other pods and they'll try something. Yeah? And it's really complicated. I've had a patient in today, and his journey has been a nightmare for him. In just 20 months, he has ended up having 2 courses of shockwave, 2 high-volume injections into his tissues to distend the tissues and cause microtrauma to the tissues. He's had multiple courses of physiotherapy, he's had 3D gait analysis, he's had orthotics, and he's ended up on my doorstep today saying, can you fix it for me? Yeah? It's not going to be straightforward for me just to say, oh yeah, this is it, that's the bit that's missing. He's even had the steroid injection as well. He's had the whole kitchen sink thrown at him. It's a slow process, and it's not like that, it is like that. And that's just the biological side. When you take on board the psychosocial, then suddenly it becomes a lot more complicated. So all those in the Facebook group, please be aware that when somebody posts up and says, I've got this, how do I fix it? All those people in that group are going to be like the friends and family down here, albeit with some experience, but they're still not going to be able to get to your diagnosis because they haven't done the assessment and done all the history in order to get to the diagnosis. So it's kind of, you're just trying different things to get solutions, and you may get lucky, and then you go around telling the world, oh, that's the treatment that's going to work for everybody, and it doesn't. So it's a complex condition. So I hope that's busted some myths around plantar fasciitis. May not have given you hope for whatever treatment plan you're on at the moment, But hopefully it's given you some hope that there are solutions out there. It can be fixed. Yeah? And we fix it all the time. Some people, we don't get as much progress as quickly as we'd like, but others get resolved brilliantly, really quickly. But those that struggle, we're going to support them and help them along that process so that actually they get to resolution. So,
Probably patience is the key word.
patience for patients, yeah. Yeah, it is, absolutely. Yeah. But if you're following the advice that says, actually, don't push yourself out of that zone of optimal stress, yeah, and be aware that a lot of it's output from the brain rather than from the foot, then you're going to be in a much better place. You're going to be educated to be able to manage your own expectations better. Yeah? Like that complex one I had today, he says, I want you to cure it. 20 months, you've seen a professor, you've seen specialists in London, you've had all this treatment, and you come to me and you want me to cure it? So we've got to manage those expectations and say, actually, what we're going to do is we're going to hold your hand through the process so you get more confident to be able to use it, because I think there's catastrophisation of pain is a fear of it coming back and being worse. It's part of the problem there. So we are live, so if you want to ask questions, you don't mind them being out on camera, that's great. If you'd rather wait until we turn the cameras off, then ask individually afterward, that's fine. We can't give individual advice for a specific condition because we haven't diagnosed, okay? So it can only be generic. We do have Dave, who's very kindly come along here today as well. Dave's a podiatrist who's got a master's in all this stuff, but he's also a social media guru and videographer and business coach and all sorts of things.
I can't iron though.
But he's great support of these things, because if it's a question that I can't answer, I'm sure that he can. So, any questions, or do you want us to turn the cameras off?
I've got a question from a running point of view.
Yeah.
What's your perspective on the different kind of structured or supported shoes that, you know, you go to a sports shop, you have a gait analysis, and then you put in, you know, neutrals or supported or whatever.
Yeah. So the thing with the running shops is they really are taking it, understanding foot function from 20 years ago, 30 years ago, what I trained with, which was I was either pronated, supinated, and that's the cause of the damage. Yeah. But we've moved on in our knowledge of that. But they use that because it's really simple, because they can stick a camera on the back, look at the angles of those heels, and go, you're pronated. Therefore, you need a trainer that's an anti-pronator. Yeah. And we'll sell you that as a solution. But that's not how it all works. But it's a really easy sales gimmick. Yeah. So they hang on to that, unfortunately. So the advice we give is buy whatever running shoe is comfortable for you. Yeah, whatever that is, because you're more likely not to have problems if you're wearing something that's comfortable. If you go into a neutral shoe, an anti-pronator shoe, and it's uncomfortable, and you put it on a neutral shoe and it's comfortable, even if you're a pronator, yeah, then bear in mind it's the normal distribution curve, so some will be pronated, yeah. Then go with the neutral shoe. Don't go with the anti-pronator shoe. And actually, there are moves that nowadays to actually they're reducing all this anti-pronation shoe stuff.
Different shoes load different tissues differently. There's actually a study which came out in the last few days which shows that the injury risk is not significantly changed by sticking any one of the things that put them in a neutral shoe. So comfort is the best thing, but there's so many other things to look at. There's things like stride length, there's are you a forefoot runner, are you a midfoot, are you a rear foot, what kind of distance are you doing? So it can be fairly complex, but get comfort first.
Okay. Thank you.
Anybody else? No? Well, thank you very much for coming along this evening. I hope you found it informative. I hope you understand why we've done this as an event, in order that we can educate, and you can go and share this information with anybody that asks you about heel pain, and understand that there's so many different things that can play a part on your individual heel pain. It could be that you're just wearing the wrong shoes at the wrong time that's causing the problem, and actually everything else is fixed. It's just a certain pair of shoes is causing an irritation for you, or an activity is causing an irritation for you. And actually, if you look at your lifestyle, that you could tweak things to make it easier for your tissues to fully recover, and for your psychosocial to get on top of it as well. Okay. Thank you. If you want any of the QR codes put up, then I'll put them back up again. And we'll say bye-bye to Plantar Fasciitis UK. Thank you for watching, everybody. See ya.
Round of applause, I think.